So my name is Nini, and I'm a attending physician at UAB. And it's my great pleasure to be here today to talk about opioid epidemic and therapeutic strategies. So I'm asked to stay here, and I cannot move around, which is very different from the usual way I do. So I apologize if I move around. And I have no disclosure relevant to today's talk. And another thing I want you all to realize is sometimes I speak very fast, and also I have pretty good accent. If that's the case, someone please just raise your hand and call my attention so I can slow down. And the reason I'm here is to deliver a lecture, but I want myself to be understood by you and can change the way you practice after you hear about my lecture. So I have a few objectives I want to reach today. So the first one is how do we define addiction? And then talk about what happened in the United States. Why we talk about opiates and opiate epidemic all the time. What happened to this country in the last few years? So when we have a disease or when we have the patient in front of us, what can we do? Are we going to feel helpless and hopeless, or besides that, can we do something as a clinician or as a medical professional? So the last, I want to introduce some medications that are approved by FDA to treat the patients with opioid use disorder. And another thing I want to say is, I want today's lecture to be interactive. So you feel free to stop me in the middle of my talk and ask me questions and for some discussion. So what is an addict? And when I am in my office or in the ER, and many times I heard from my patients, I said, so I usually start the interview with, how can I help you? And sometimes they will say, I'm an addict. And the attorney asked me to come here. Or since I see many patients with from criminal justice, so they usually say, the judge asked me to be here. I'm an addict. So I hear a lot from the patients in different settings. So then others, and how can I help you? I'm running out of my medication. You give me medication. So something my job is just write a prescription. And another thing is I don't know how to control myself. And then I think I'm not smart. I come here for the magical pills. So another thing, probably you also have experience. These patients, you just want him or her to be out of your office. And occasionally in my office, this does happen to me, patients lingering in the office, and they refuse to leave the office because I refuse to write them prescriptions. So sometimes I have to say, if you don't leave my office now and don't allow me to see the other patients, I have to call police. So these are all the way in the community we describe the patients who are struggling with addiction, or they label themselves. So in the community or in the general idea, addiction is kind of continual use of a substance or engagement in activities we know it's not healthy, we know it's harmful, but they continue to use. But in the medical field or in the professional field, addiction is considered as a brain disease. This concept was brought up in 1996 by the NIDA head, Dr. Nashmer. He was the first person who labeled or who defined addiction as a brain disease. It's more than behavior change. It's including many different areas when we struggle with addiction. So why people or why patients are addicted to a certain substance? Because our brains, right? We are controlled by our brains. Our brains tell us what to do, how to do, when to get up, what kind of things we do, we are enjoyable, we are pleasant. So that's because our brain control our behaviors, also control our thoughts. And probably like all the people when we are in our training, we heard about so many things like substances per se, like so many substances here, amphetamine, you name it. And that's one of the major brain areas that is involved in the addiction. We know it's the limbic system, right? And nucleus accumbens. These are all the organs in the brain that are play critical roles in the addiction. So no wonder back to 1996, addiction was defined as a brain disease. And besides that, addiction in the recent 5-10 years, addiction is also defined as a chronic disease. There are many reasons behind it. First, we have to accept it, and we have to acknowledge that. Otherwise, it's very hard for us to take good care of our patients. Second, like any other diseases, like diabetes, hypertension per se, or heart failure, and the patients have to be treated for the entire of their life. And addiction is the same thing. It's not the 1 day, 1 month, 1 year thing. It's for the rest of their life. And the recovery itself takes time. This time can be many, many years. So many times when patients come to me and I treat them with medications, with therapies, the next question they will ask, Dr. Li, how long I should see you? So just like when we have flu, we are seen by our physician, we will say, do we have to take a medication for more than 7 days or for more than 3 days? So we are always curious, the duration we have to be in the treatment. So that's like things. So in the medical field, this is the addiction definition. It's a primary chronic disease involved like a brain reward, motivation, memory, and related circuitry. And also cause lots of dysfunctions leading to like biological, psychological, social, and spiritual dysfunction. And so in the patient, we can see patients spend tons of time to pursue reward for these substances. And there's like two institute or organization. One is the psychiatry, which is the field I belong to. I also belong to the ASAMS, which is the American Society of Addiction Medicine. So I belong to these two organizations. And the interesting thing is these two organizations have a little bit of different definitions for the addiction. Per se, DSM-5 is the kind of gold standard we use in psychiatry to assess patients, to diagnose patients. But the ACMs just have a little bit difference from DSM-5. However, no, regardless of the difference, the treatment itself is very similar. So after we talk about addiction, then we come to what is opium addiction. And so I want to ask a very brief question in the audience. How long have you heard from, per se, radio or social media or TV or books or newspapers? You heard about the opium epidemic. Do you hear about it every day or every week or every month? How many do you guys hear about it every day like me? So how many do you hear about it per se every week? So you can see this is really involved in our daily life, opium addiction. And what happened in the last 5-10 years, this particular term come to our life. And we know many celebrities, you can give me a good list, and they suffer from undiagnosed opium addiction or other substance addiction. However, for different reasons, they are undertreated before their death. So this celebrity, I like his music so much. And his death really hit my brain and my heart. And you can see the other musicians, famous singers, they also died of overdose. And there's a particular reasons that opiates become so academic, because have you ever heard Americans are in pain? So back to 10, 15 years ago, there was a fifth vital sign, which asked medical profession to assess the pain level in patients, or even in the non-cancer patients. So that was in a few years ago. We were under stress or under pressure to treat the patients who have pain, no matter acute pain, subacute pain, and chronic pain. And especially for the chronic pain, we feel when we assess the patient's pain level, we ask them, how do you scale or label your pain level? Patients from 0 to 10. When patient says I'm in pain about 5 out of 10 or above, we are just feel nervous and anxious. I feel oh goodness, your fifth vital sign is 5 out of 10 or even above. I have to give you something so you can have less pain or less suffering. So we were under pressure, we were anxious to treat the patient's pain. Then the outcome is we may overprescribe pain medication. When we went to a dental office after tooth extraction, it's very usual, normal for us to receive 1 bottle of Nortab or Percocet, 5 or 10 milligrams, and 30 to 45 or even 60 tablets, right? It was so normal, usual in the past, but not in the recent 2 or 3 years. So many Americans suffer from chronic pain, and physicians were anxious to prescribe pain killers for them. So many reasons and contribute to overprescription of pain medication. And pain, opiates, and addiction, they are kind of go by parallel. They are not separated at all. So patients come to you and in the hope of receiving medication to relieve their pain. So we give them prescriptions, and the patients are happy, we are happy. However, after our happiness, there are lots of other consequences after we prescribe pain medications. Patients could develop tolerance, and if you stop prescribing pain medication, they will have withdrawal symptoms. And if you overprescribe, patients may overtake medication, patients may divert medication, and the patient's tolerance for pain is also reduced. So this is form very good cycle, back and forth between pain, opiates, and addiction. Of course, when patients have all these unexpected or negative outcomes from prescription, they will not be happy anymore. And of course, we are not happy either. And you can, this is the data I extracted from CDC in 2012. And this is the in the United States. You can see Alabama is one of the 5 states that per 100 patients and how many medications we prescribed. So sounds every single American received at least 1 tab in that particular year per this data analysis. This is when we have increased medication and overdose deaths come to true. So in 2016, CDC reported that overdose deaths from medication and other opiates was only 7,000, and the last year was 72,000. That's reported, and people suspect that there are many patients who overdose deaths probably are not reported at all. So increased opiate-related deaths really hurt our heart and our political field. And even in Jefferson County, and my own patients overdose deaths, I was called by our judge and called by the patient family when my own patients overdose deaths. So this is such kind of things like really involved in our daily life. And look at this data in the last 17 years, from 1999 until 2016, and look at different curves. For the methadone itself, so methadone came to the market in 1964, and the methadone, the overdose deaths, actually with the increased overdose deaths to the heroin and the other opiates, methadone overdose deaths actually kind of tended to trending down. But look at the other opiate overdoses after 2010, just shoot up so quickly, and there's two contributors to these significant curves, sharp curves. One is the heroin, one is the prescribed opiates from physicians. So one of the reasons for the heroin was so popular in the addiction is it's so cheap, so very available, and kind of $10 you could buy even 1 to 2 bags in the market. And if you look at overdose deaths in 2016 and divided by the age group, and 45 to 54 is the highest compared with other age groups. And I don't know what's the real reasons behind these curves, why 45 to 54 age group is the highest. Probably there are many reasons, stress, right? When we are under stress, we easily put things into our mouth, like food or drugs, to relieve our stress. But I was trying to look at the reasons for this age difference, and I have not found any mechanism yet. And look at by the states, and good things in 2012, Alabama was one of the most prescribed states, but overdose death in 2016 actually was better than many other states. So that's a good thing. And so in back in 2016, CDC was, I think, was outrageous by overdose death. So they come to very clear guidelines, and was released in March of 2016 about how to prescribe medications to manage chronic pain. These are all the drivers or mechanisms for them to come up with these guidelines. And I want to summarize in 3 sentences about their 12 recommendations. First, you have to determine when to initiate and how to continue to prescribe for your patients who have chronic pain. Second, you have to be careful when you prescribe what to select, the dosage, duration, how often to see patients, when you should discontinue medication. And also, when you start to prescribe medication, you are requested to discuss with your patients the likely treatment duration or length, not indefinitely, either 3, 7, and 10, 12 days. So when you have this conversation with your patient at the very beginning, it's much easier for you later on to talk about discontinuation. Otherwise, no one will be happy in the office. Also, clear document why you prescribed. What's the likely risk and the benefits when you prescribed? So documentation is very important. So these are 3 main recommendations that come up in 2016. And I know this slide is very busy. I don't want to read from the first sentence to the last. But if you Google, probably many of you have been aware of already. For some of you who are curious, you just Google CDC recommendation on chronic pain in 2016. You will come up with these recommendations. Very clear and very easy to follow up as long as we wanted to follow up. So why do people develop addiction? Like in the first few slides, I talk about it because our brain, we are controlled by our brain in terms of our thoughts, in terms of our actions. This is like more like a psychological things. Actually, there's like biological or physiological reasons why patients develop opiate use disorder or opiate addiction. So biologically, like opiates have so it's very clear that opiates has 3 receptors. So the number 4 receptors are, uh, are still in the investigation. We are not very clear of its nature or structure and function yet. But for the other 3 receptors, we are pretty sure what they are doing and where they are located and what roles they play. So these are like 3 different receptors, like mu receptors, we heard or not, and delta and kappa receptors. So when we take medications, per se like opiates, or when we have like a non-prescribed opiates per se, like opiates poppy or like a heroin or something like that. These, I just say these drugs come to our brain and bind to the receptors in the brain. And then after these all the reactions, so the outcome is we feel happy, our pain is relieved, and for the patients who overtake medication or who use heroin per se, they can tell you they are extremely happy, they are euphoric, and they will tell you, I just have high feelings, which pursued make them to keep using medications or keep using drugs. So we have biological reasons, we have psychological reasons or social reasons for patients to develop opiate use disorder. And this is like kind of similar to the last slides. And when we use prescribed medication in an appropriate way, it's like for the medical use. But sometimes we have a non-medical use, or sometimes our brain trick ourselves, and like receptors per se can be desensitized and can be adapted. So patients have to use more or higher dosage than they did before to have the same feelings. We call it tolerance. Another thing, like when patients overuse medications or they stop medication in a cold turkey, they will have lots of symptoms, which we call withdrawals. And when they don't use, they are craving. They just feel the end of the world. They just want to die. And so there's not like a physiological role, and they have a pathological role when we use like opiates. So when we identify patients who struggle with addiction or with opiates, so how can we treat them? Do we just say, you have to stop using it to put your life back to the right track? So stop using, which is we advise our patients in order to do certain things. So does it work? So for the nicotine dependence or for the nicotine addiction, the research says physician advice works 50% of the time. So if you are willing to talk to your patients about how to stop smoking or nicotine use, it's very helpful. However, unfortunately, for the opiate addiction, physician advice may work, but very minimal. And when the opiates are overused, we call it overdose. So you use a higher dose than usual, and the patients present to you with intoxicated symptoms. And probably, I'm not sure how many of you have seen the patients who overdose opiates come to you in the office, even in a restaurant, in a Walmart. I had experience, that was 7 years ago. I was at a Walmart to check out, and a patient right before me and just sniffed in front of me. And I was so panicked because I did not bring anything with me, and there was no knocking keys at that time. I pulled out my cell phone, dialed 911, and when I checked the patients, I see exactly these 3 symptoms that I saw the patients. And my pupil size was so tiny, barely can see that. And shake him, no response. And touch his breast very shallow, very slow. So I did a CPR on him, and the other people helped me. My husband was next to me, and he was very helpful. So the patients come back. But I just want you to understand, opiate overdose happens everywhere. You have to be mindful and to recognize. And simple thing, just I teach my resident medical students all the time. Just look at the people's pupils, the size. If you cannot see it, 99% of the time, patient overdose opens. And so very easy to recognize on overdose. And these are the other pulmonary edema and seizure also could happen when people overdose opiates. So just opposite to the this is the management of opiates overdose. So depending on the settings you see the patients. If a patient present themselves or brought to the ER, and so the of course naloxone, right, is antidote, very specific antidote to the opiates. So naloxone, and if you can find IV access, and use naloxone. And very fortunate thing, I'm very glad is knocking kit is available in so many pharmacies everywhere. We put the knocking kit in the ER, patients can request without any cost. And the Walgreens pharmacy, CVS pharmacy, many local pharmacies, they have this kit. In the office, I even put a knocking kit in my car, a few of them, just in case. So just feel free to, when you see the patients who overdose on opiates, feel free to ask people around you, Walmart, Publix, when they have pharmacy, they have these free kits to apply to the patients. Feel free to ask for that. And this knocking kit is really just so simple. And I should put a picture here, so easy for just intranasal, 0.4 milligram, and wait for 2 to 3 minutes. If a patient don't wake up, another nose, another intranasal use, another 0.4 milligram. And of course, at the same time, you call 911, right? Okay, this is just the opposite to the overdose, is withdrawal. Patients running out of medication or running out of money, and they go to the cold turkey. So these withdrawals symptoms you see in patients. And how soon for the withdrawal symptom to happen kind of depends on the medications or the drugs patients are using. So for the heroin withdrawal, for the heavy users, probably less than 6 to 8 hours. And for the methadone, patients may have emotional feelings, but they don't have a real full-blown withdrawal symptoms until 3 days. Also for the buprenorphine, the same thing. They are good in the first couple days, but they may tell you they cannot sleep. So for the withdrawal symptoms itself, we can have physical withdrawal symptoms, and you can see when you assess patients and physical signs, and you can check on the patients for blood pressure, heart rate, and the pupil size. So when patients are in a withdrawal, the pupil size will go big, from 6 to 7 until to 10, huge pupil size. And you can see patient tremor in front of you, just shaky. They cannot hold their shakiness, stop their shakiness. And lots of signs, physical signs and physical discomfort, sneezing, yawning, nose running, and vomit, and joint pain, and cold, sweat, flash. So opiate withdrawal symptoms are similar to opiate overdose symptoms. So easy to identify and to recognize. And COWS, clinical opiate withdrawal scale, is widely used in the clinical setting for us to assess severity of withdrawal. So kind of tell us how, what kind of appropriate way we should apply to treat the patients. And this also available if you Google it. And so when patients are suffering from withdrawal symptoms, they are craving, they are suffering, they have physical symptoms, they usually have to go back to the drugs to relieve their withdrawal symptoms because it's so uncomfortable. And if they are in the hospital, we could treat them with specific medications, per se methadone or buprenorphine, or we can treat them with some medication just to relieve their symptoms like clonidine, gabapentin, like ibuprofen, Imodium, and Zofran. So it depends on what symptoms they tell us, or depends on what symptoms we observe from them. However, opioid detox is far less than enough. Look at this relapse rate. So patients are in the hospital for 3, 5, or 7 days. We finish detox. We said, okay, you are good, and the patients are good. They are happy, you are happy, and you discharge them. If you don't set up very clear, very detailed, constructive recovery programs, they will relapse. 99% of the time, they relapse. Many patients, why they come back to the ER 10 times per month and 20 times per year, right? Because when they finish detox, their cravings is still there. They will go to the place to buy their drugs. So detox is far less than enough. We have to do more than detox. And this is like a treatment model. For the ACMs, we want to adapt to use it in our practice. So patients enter the door and start like a detox. And after finish detox, we want to move them to the residential rehab if they meet a sort of criteria. And I don't want you to understand that a patient has to go from one step to another step. No, that's not the way we should do. So some patients, if they are very severe, they have to go to one step to another step. However, many patients can jump from step after they finish detox. They may not need a residential. They just can go to the IOP, which is intensive outpatient treatment. Or they can even go to like outpatient care, go to your office for the treatment. As long as they go to like counseling per se, they go to AA meeting, NA meeting, or CA meeting. They have to find programs that they could feel comfortable to talk about their addiction and to hear about other people's experience, to find different coping skills for the addiction. So basically, these are the options they have, and you just have to come up with a treatment plan with your patients, depending on how severe their addiction is. So when I was started with addiction clinic, I started using medication to treat the patients. Many times, patients, their families, and friends just say, you just use one medication to replace another drugs. So that's why I come up with this slide, and actually I print out this slide, put it in my office, and I provide education to them. Yes, I'm using medication. However, this medication is different from the other medications. Has what kind of critical roles you could have when you are on a medication, and I can prevent from 3 preventions, and 3 decrease, and 3 increase. So I just go over with them like a 3P, 3D, and a 3I with them. I want to convince them or use education that this medication can help you to put your life back to the normal. And you will feel normal in a few years, and your life will be changed. It's kind of life-saving medications. So if you keep doing what you are doing now, the outcome will be overdose later on. or either end up in jail or prison for the rest of your life. So that's the kind of education slide I came up with patients, and they are very convinced by the way I deliver to them. So, like I said earlier, there are 3 medications that are approved by FDA in the last 40 years to treat the patients with opiate use disorder, and they are methadone, naltrexone, and buprenorphine. And methadone, I don't use methadone very often except in the inpatient unit. The reason is methadone clinic is run by the government, and you have to go to methadone clinic to be treated. And so this is I get it from PubMed. So methadone therapy come to the it was approved in 1964, so it has been a long time, over 50 years. And methadone, we know, it can be used to treat the patient pain. So when you use methadone to treat addiction versus the pain, the dosage range is a little bit different. So addiction is a little bit lower dosage. Usually have to be 60 to 120 milligrams per day. And of course, it has the similar benefit as other medications. So for the methadone clinic, in the first 6 months, patients are required to go there every day, even on the weekend and the holidays. So 6 months later, if they are doing a good job, they are able to take home medication that go there only 2 times per week. So gradually every week, every month, or every other month. And the patients can stay with methadone clinic for the rest of their life. So this is buprenorphine, and I kind of deal with every day in my practice. And buprenorphine is a different medication or different opiates because different from a methadone or fentanyl patch. They are not a full agonist. They're like a partial mu receptor agonist, and has a very long half-life. So depends on if you are fast metabolizer or slower metabolizer, and can stay in your system for a long time. So you don't have to dose patients every day. You can dose patients every other day and every 3 days. And of course, buprenorphine has side effects, which is, so in my practice, 7 years, the most common side effect is constipation. And so always ask patients if they are constipated. And but very good safety profile, and very little respiration, depression, and very little overdose concern. So this is receptors buprenorphine can work on, and the mu receptors, partial mu receptors and the kappa receptors, and opium mega receptors. And I'm not sure how many of you see dual diagnosed patients, means the patients have addiction and also have some other psychiatric illness per se, depression, anxiety, and many times when patients are stable with the buprenorphine medication, and when you reassess their depression level and anxiety level, and at least 50% of the time they will say, I don't feel depressed anymore. And you can see I'm so calm, so I'm not anxious. The reason is buprenorphine can work on the kappa receptors. It's sorry, and it's antagonist. And this receptor we are trying to figure out in the humans, but in the animal data, it shows that can treat a significant depressive animal in models. So I hope in the human clinical trials, we can approve that it can also treat depression. And so buprenorphine is a partial agonist, and methadone is a full agonist. Naltrexone or naloxone is antagonist. So you can see on this right side, I put the arrow here. The reason I put the arrow here is buprenorphine, the affinity compared with other opiates in the middle. So that means if your patients are currently taking morphine and patient come to you says, I wanted to be on the buprenorphine treatment for my pain or for my addiction, you probably have to be careful because this medication has very strong affinity, but it is a partial agonist. So if you use buprenorphine to replace morphine, your patients will have withdrawal symptoms. So just have to be careful and explain to patients, slow down the transition from morphine to buprenorphine. And this buprenorphine feature is a partial agonist. So even though you give a higher dosage per se, higher than 20, 24, even 32, because it's a partial agonist, so it has a ceiling effect. And the patient may not feel significant dose-dependent effect when the dose is higher than 20. And so that's why it's much safer than other opiates, including methadone. And also withdrawal, patients may not have immediate withdrawal symptoms because of long half-life. I made this table. I just want to compare the similarity and the difference between different opiates. And you can see for the buprenorphine, it's less sedated, less respiratory depression, and better tolerance. And so it's much safer. And so that's why FDA approved it back to 2000, and the DEA allow us to do office-based treatment for patients with opiate addiction because of safe profile and a very effective medication. And also it's safe to use in the patients who are pregnant, who are older than 65 years old, and who are have chronic kidney dysfunction patients. So have a pretty good safe profile. This is just a routine workup when you decided to initiate the buprenorphine in patients. Very similar to what we are doing every day. Get a medical history, to run some lab tests, and get a connector information, and educate your patients before you start patient with new medications. But there are a lot of concerns behind it too, even though it has a safe profile. Patients may not take medication you prescribed. They will divert medication. And the patient may go to different physicians to ask for the medication and to sell it on the street. And so I just have these kind of things talk about it with patients in the front when we have a relationship. And in the first couple of years when I started this clinic, I had a lot of kind of disagreement with the patients. So then I come up with a treatment agreement. And this is the treatment agreement I have been using in the last 6 years. I found out that after I started using this agreement, patients are committed to it, I committed to it, our treatment team committed to it, and I feel like the outcome are much better than the first year. And so I just feel like it's very good to have the whole introduction or the whole overall introduction of the clinic, and you can tell the patient what we expect from them and what they expect from us, and to work together to have a good relationship. And of course, the urine drug test for the patients who are taking opiates. And urine drug test we use all the time in the clinic. And sometimes this can be very tricky when you interpret the results. And of course, sometimes results can be false positive or false negative, or urine result does not show the medication you prescribed. So all different kind of things you could see in the urine drug results. So we have to know how to interpret our results. If patients don't agree with their results, what the next step is, we can send for the further test, for the confirmatory test, or we can retest the patients right in front of you. So you need to kind of observe the samples. And this is like PDMP and currently is mandated by state, but it's not like a national level. So Alabama is able to access 10 different states as well. So that's good. And in case patients travel around for the medications, and we are required or we are highly recommended to check the PDMP when we prescribe the controlled medications. So this success rate for the buprenorphine treatment is very high success rate. So one study was done in 2003, and very really astonishing results. Compared with the control group, the retention rate is very high. Negative urine test results are very high. So it's very encouraging for the clinicians to do this medication or to treat a patient with these medications. And this is another medication which is antagonist, Vivitrol shot. So Vivitrol or naltrexone are very good medication. However, has very good requirement for patients. And I only in my own practice, Vivitrol probably only I use the about 10, not more than 20% of patients. Two reasons behind it is patients have to be very motivated. Instead of you are motivated, sometimes I'm very motivated to treat a patient with Vivitrol shot. However, they are not motivated, and so they are so sick when they relapse. That's the kind of thing I learned from my patients. So when you identify patients who are motivated, have very good social support, and probably Vivitrol should be your first option to discuss with your patients. I know it's crazy, and this is heroin maintenance treatment in the opioid addiction patients. And this happened currently. There are a few clinical trials running in Switzerland and Canada. And just some physicians know that that's what back to 30, 40 years ago, we used the alcohol to treat the patients with alcohol use disorder, which is the same thing like heroin. My personal wish is I don't want it to happen to the United States. So that's my personal opinion. So again, recovery is a long time and a lifelong journey, and should be completed or should be finished by a team. And in this particular team, including of course the patients, family, friends, clinicians, nurses, social workers, and therapists and community. And if without this all the support, it's very hard for our patients to be on the this long-term journey. They do need support and from different personnel. Okay, this is my last slide. So with that, I would thank you for your attention to be here and listen to my lecture. And if you have any questions, please feel free to send me an email. This is my email address. If you have any questions in terms of my today's lectures or in terms of any medications I talk about in my lecture, and or on some slides, please feel free to get in touch with me. Thank you so much.